it is very, very helpful for them. So what's the diagnostic criteria for diabetes? Symptoms of diabetes plus casual plasma glucose concentration or the fasting or the random plasma glucose of more than 200 milligram per dl, or fasting plasma glucose of more than 126 milligram per dl or 7 millimoles per liter, or 2-hour post-load on OGTT is more than 200 milligram per dl. Any one test should be confirmed with the second test, most often a fasting plasma glucose test. This criteria for diagnosis should be confirmed by repeating the test on a different day. So 2 tests should be done, and then it should be repeated on some other day as well to confirm the diagnosis. Any of these 3 can be used when, and one of them is, and the second test which should be done should be preferably a fasting plasma glucose test. So how do you categorize the glucose test status? Fasting plasma glucose is normal when it is less than 100. It is called impaired when it is between 100 and 125. And it is diabetic fasting plasma glucose. Patient is labeled diabetic if a fasting plasma glucose is more than or equal to 126 milligram per dl. 2-hour post-load plasma glucose or oral glucose tolerance. Normal plasma glucose is less than 140 post-load. Impaired is 140 to 199, and patient is diabetic if the levels are more than or equal to 200 milligram per dl. So we have talked about this. Type 1, polyuria, polydipsia, polyphagia, the clinical presentation, weight loss, weakness, and dry skin. And this ketoacidosis can be the very first presentation of type 1 diabetics. Type 2 diabetic patients can be asymptomatic, can have polyuria, polydipsia, polyphagia, polyfatigue. They will be having weight gain. When type 2 diabetic patients who is on treatment starts having weight loss, develops the polyuria, polydipsia, then you have to consider that they are now developing insulin insufficiency, insulin deficiency, and now they will be needing insulin treatment. Most patients are discovered while performing urine glucose screening. So most patients discovered while they are performing urine glucose screening. Excuse me. So what are the desired outcome? What do we want in these patients? We want their symptoms to be relieved. We want the mortality to go down. We want to improve the quality of life. And most importantly, we want their microvascular and macrovascular complications to reduce. The risk of having them is reduced, and the damage being caused because of diabetes is reduced. What are the macrovascular complications? It's a coronary heart disease, strokes, and peripheral vascular disease. Microvascular complication is the retinopathy, nephropathy, and neuropathy. We'll be talking about them in my second lecture. So how to treat these patients? A very, very busy slide. You can see very important, very, very important for the clinicians. What is advised is you start with monotherapy unless the HbA1c is greater than or equal to 9%. So if it is more than 9%, then you have to consider the dual therapy. Or unless the A1c is more or equal to 10% and the glucose levels are more than or equal to 300, or patient is markedly symptomatic, consider combination injectable therapy. That is the insulin or non-insulin injectable therapy you have to think of. So if the HbA1c is less than 9, you start with the monotherapy. But starting before going off to this monotherapy, the first thing you have to do is the lifestyle management. So lifestyle management at any level of HbA1c is the first line of the treatment. You have to advise to them. So if HbA1c is less than 9%, it's 6.5 to 9%. Actually 6.5 to 7, you can advise the lifestyle management, you can see, and then from 7 onwards you give metformin. Metformin is the first line drug. Metformin, which comes by the name of glucophage or newphage, is the drug which has to be given. Initially, it was said to the obese patients, but now obese, not obese, type 2 diabetic, start metformin to these patients. It is found to be very effective, has low risk of hypoglycemia, do not cause weight gain, and it usually helps in weight loss and keeps the weight normal, so it doesn't have a bad effect on weight. The main side effect is the gastrointestinal effect, so it causes GI disturbances. Lactic acidosis is also mentioned, and it has not been seen that much, but it causes lactic acidosis. If A1C is not achieved, you give metformin for 3 months, and if it is not achieved for 3 months then of monotherapy, then you do a 2-drug combination. Order is not meant to be to denote any specific preference. You can do any one of these, and this can also these drugs, there's a list of these drugs, and you can choose any one of them depending on the patient and patient's requirement and patient's condition. So one of the drugs, uh, like sulfonylurea, you can give to the patient if the patient is not obese, because sulfonylurea can lead to the weight gain. And a patient who has heart failure, you will not consider giving thiazolidine diones to this patient. Then a patient, you can give DPP4s. These SGLT2s have shown those with cardiovascular disorder, you can give them. Those having ischemic heart disease, then SGLT2s have been considered better option. It's a better option. Here there is a GLP-1 receptor agonist, which have a very good side effect, that is weight loss. So they help in weight loss. So on all those type 2 diabetics who are obese and they need weight loss, you can start with GLP-1 to them. And then the insulin, basal insulin, can also be added to these patients. Again, you give the combination metformin plus sulfonylurea, metformin thiazide, metformin or DPP4, so metformin or SGLT2, so metformin and GLP-1, or metformin or insulin, whatever combination you're giving. You see these patients for next 3 months with the dual therapy, and if not responding, you proceed to the third drug. And this, again, the order is not like this one and then go to this and then this and then this. No, you can choose according to the patient's requirements. So if HbA1c not achieved approximately 3 months of triple therapy, and patient is on oral combination, move to basal insulin or GLP-1. So you have 2-3 options after that if on triple therapy it is not helping. So what you can do is you can move to basal insulin or GLP-1 receptor agonist, or you can go to GLP-1 receptor agonist, add basal insulin, or you can optimally titrate basal insulin and GLP-1 or mealtime insulin. So you have a lot of options. You can juggle between the drugs as the patient, looking at the response of the patient. So how will you give the combination injectable therapy in type 2 diabetic patients? So what you do, you will basically do a basal insulin. So what is a basal insulin? Is the insulin which will cover the basal levels, which will give insulin, you give the insulin for throughout the day. So one dose in an agent which will cover the insulin, the basal levels of the insulin, not the parendial. So parendial is what insulin you give with the food, that is the parendial insulin, and the insulin which you give along with for throughout the day, which gives the coverage for throughout the day, not thinking of the uh, food patient is taken, is called basal insulin. So you start with the basal insulin with metformin or other non-insulin agent, and if HbA1c is not controlled, you go to a you add a rapid acting insulin, the insulin which controls the perennial sugars, that is the sugars rising after taking food, or you add the GLP-1s, or you can change to pre-mixed insulin, so a mixture of insulin which has the rapid acting insulin and long acting insulin, you can give them. So we're going to come to these insulins and we'll talk about them. this is how it has been advised how the therapy should be done. So don't get confused. We're going to come to these different type of the insulins in the later slides, and then you can come back to this slide and have a look at it. Then you will understand it much better. So what is the impact of intensive therapy for diabetes? So there have been several trials which have been done world over. The major trials which have been done are UKPDS and DCCT and Accord Advanced Reddit. They are mentioned in your books. You can go through them. What the main thing we have come to know about is that by intensifying the therapy, what they saw that all the microvascular that by intensifying therapy there is a very good effect on the microvascular complications. So all microvascular complications are controlled by intensifying the therapy for diabetes. But we're not sure about the macrovascular, and we are not sure about the mortality as well. It has not good effect. It has not significant good or bad effect on mortality. It has also been seen in Accord, it was seen that there was excessive mortality by intensifying therapy, and this excessive mortality was actually because of the increased hypoglycemic episodes in these patients. Intensifying the therapy led to hypoglycemias. So that's what we need to be very careful about. uh, the main complication we have to be very careful in these diabetic patients when we are intensifying therapy is hypoglycemia, because that can lead to increased mortality. So what are the anti-hyperglycemic therapy or glycemic targets? So HbA1c should be less than 7, preprandial glucose should be 80 to 130, postprandial should be less than 180. So before meal or fasting should be 80 to 130 on treatment, and after meal it should be less than 180. We have to keep it in a way that there is no incidence of hypoglycemia. Whenever there is hypoglycemia, we have to loosen the control on the glucose. This treatment has to be individualized. It depends on patient to patient. You can go for more stringent kind of control from 6 to 6.5 if duration of the disease is short. If it is a younger patient who is very healthy, very motivated, has no complications, no cardiovascular disease yet, you can go you can you can go for a stringent control of 6 to 6.5, and you can go for less stringent from 7.5 to 8 if the patient has several comorbidities, if there is hypoglycemia, if he is old age patient, if they is less motivated, doesn't have support, or has limited resources, then you can go for a less stringent control. So this is what I see, that even if we keep the glucose at HbA1c target less than 7%, we see that the control patients, many patients are not at this recommended goal of HbA1c. So there is ominous octet of DMT. Diabetes mellitus has ominous octet. This is the mechanism by which hyperglycemia is taking place in diabetes mellitus type 2. So we have impaired insulin secretion, and there is increased glucagon secretion, which we have talked about. There is increased high glucose production by the hepatic glucose production. By the liver, there is increased glucose production. There is neurotransmitter dysfunction. There is decreased glucose uptake. There is decreased glucose reabsorption, decreased incretin effect, and there is increased lipolysis. These are all the pathways which are responsible for the development of diabetes, and we have now developed drugs which act on all of these pathways and have helped in improving this hyperglycemia. We will talk about them as we go, as we talk about the drugs. So first thing to do is the diet. Dietary advice which should be given to the patients is that their fat should be provided 25 to 35% of total intake of calories, and saturated fat intake should not exceed 10%. Cholesterol consumption should be restricted to 300 milligram or less daily. Protein intake should be 10 to 15% of the total energy requirement increase for children during pregnancy. It should be derived from both animal and vegetable sources. Carbohydrates 50 to 60% of total caloric content of the diet. Carbohydrates should be complex and high in fiber. So it should have it should have low glycemic index. Glycemic index is when you take a food, the rapidity with which the glucose levels rises in the body is the glycemic index. So sugar you take and it will shoot the glucose levels at a very rapid rate. So it has a high glycemic index. And the food, their glycemic index is compared to that of slice of a white bread. So the way white bread causes the rapidly raises the blood sugar levels is considered 100%, is considered the highest glycemic index. So drugs, the food, the food substances which when you take, they raise the glucose levels slowly and gradually. Those kind of foods are known as low glycemic and are known to have low glycemic index. So, and what are these foods? These are complex foods like your um, the ones with the high glycemic index is grapes and watermelon, and which are highly sugary foods, while those like the vegetables, they have a low glycemic index. You can look up for the hyperglycemic for the glycemic index, high and low glycemic index foods, and they you can easily get these from the net, tables or charts from the net. Excessive salt intake is to be avoided. It should be particularly restricted in people with hypertension and patients with nephropathy. Physical activity is very important. It helps reduce weight and improves the insulin sensitivity. So with dietary treatment and a regular physical activity helps the patients and in controlling their sugars, but it should be according to individuals' health status and fitness. So before advising exercise, you have to rule out and you have to look for the complications. Autonomic dysfunction, the cardiovascular disease, and the retinopathy is very important to know. Patients need to be educated about the incidence of hypoglycemia. So because if the patients start doing exercise, maybe the requirement of the insulin, if he is taking insulin, then the requirement of insulin might go down, and if he keeps on taking the same dose, there are chances that he has hypoglycemia. So patient has to be educated before he starts the exercise. So we have anti-diabetic drugs. As I said, they act on all the octane of the type 2 diabetes. So we have insulin, the drugs which causes increased secretion of the insulin. Yeah, that group is sulfonylureas, meglitinides, and incretins. Then there are drugs which some of the drugs like incretins also play an important role in decreasing the glucagon secretion. Then incretins have effect on the GI, and they causes the GI, the gastrointestinal system, and we have alpha glucosidase inhibitors over there, which inhibit the absorption of the glucose, amylin and bile acid sequestrants, which can again lead to decrease the hyperglycemia. Metformin and thiazolidinedione decreases hepatic glucose output and thus decreases the insulin resistance. Thiazolidinediones also affect the fat cells and decreases the production of glucose. Glucose uptake and utilization is increased by means of thiazolidinediones and metformin, so they are helpful in insulin resistance. Glucose reabsorption is inhibited by the SGLT2. So here the newer drugs which we have been knowing about sulfonylureas and metformin, thiazolidinediones, even the bromocriptine. It acts on the brain and has a neurotransmitter dysfunction which occurs in the brain. Dopamine system, it affects that, and through that it helps in decreasing the hyperglycemia. So we have been knowing about these for decades and decades. These are the drugs. this SGLT2 inhibitors, and these are the incretins which have completely changed the face of the treatment of diabetes. And diabetes is now going to be, in few years, the monotherapy, the first line drugs, they might be changed to these are the newer drugs which might be replacing the old ones in coming future. So sulfonylureas stimulate the pancreatic secretion of the insulin. There are several generations of these. It is about the uh, so first generation is tolbutamide, chlorpropamide, and acetohexamide, which are low potency drugs, more potential for drug interaction side effects. Second generation is glimepiride, glipizide, and glyburide. They are higher potency, less for drug interaction side effects. All sulfonylurea drugs are equally effective in reducing the blood glucose when given in equipotent doses. So the duration of action is highest for chlorpropamide for 24 to 60 hours. They have active metabolite. The glimepiride is the one which is usually prescribed nowadays. It's a 24-hour duration. We can give 1 to 2 milligram. Glyburide or glibenclamide is the one which is being given advice in pregnancy as well. They reduce HbA1c by 1.5 to 1.7%. Fasting plasma glucose reduction is by 50 to 70, and postprandial is by 92 milligram per dl. Adverse effects is by the main adverse is hypoglycemia. That's very dangerous. In old age, most of the patients we have seen coming with hypoglycemia because of this. And then there is a problem of weight gain with this drug. Hyponatremia with tolbutamide and chlorpropamide has been seen. There also have several interactions with warfarin, salicylates, chloramphenicol, allopurinol, and propanacid. Then we have short-acting secretagogues, repaglimide and metaglimide. They cause insulin. They cause a glucose-dependent insulin, and so what happens? They cause the release of the insulin when there is glucose in the body, excessive glucose, and this insulin secretion is decreased at low glucose level. With lower potential of hypoglycemia, they have to be given before meal or with the first bite of each meal. If you skip meal, you don't need to take this drug. So it will only cover if the glucose is raised. Adverse effect, there is incidence of hypoglycemia is there, but it is low. Inducers or inhibitors of cytochrome 3A4 affect the action of repaglinide, and litiglitide is inhibitor of the cytochrome 2C9. Bigonides, the metformin drug, glucophage, which is the drug of choice, loved by all the physicians, all the dietitians, all the diabetologists, everyone, all the endocrinologists. Metformin. What does it do? Reduces hepatic glucose production, increases peripheral glucose utilization. It causes nausea, vomiting, diarrhea, anorexia. So you have to build the dose in these patients. You have to you start with a light dose and then you bring it to the maximum dose, 3 times daily maximum dose. Fenformin was another biguanide which was taken off because it caused lactic acidosis, and because of this, the metformin should not be used in patients with renal insufficiency, congestive heart failure condition that leads to hypoxia, and that is also the reason that metformin is usually stopped in all those patients who had myocardial infarctions, the heart attack. So it is stopped usually for 6 weeks after the myocardial infarction to prevent the incidence of lactic acidosis. Glitazones or thioglitazones, these are p-bar gamma agonists. This is paroxysine proliferator activated receptor gamma agonist. Rosiglitazone and pioglitazone, very effective. They reduce insulin resistance in periphery by sensitizing the muscles and fats to the action of insulin and possibly in the liver. Onset of action is slow, 2 to 3 months, causes edema and weight gain, and that is the reason that it is not prescribed in patients with congestive heart failure. They had a very good effect and were frequently prescribed Their use has gone down because of the high reported incidence increase in incidence of the bladder cancers with it, and it also causes osteoporotic fractures. However, now newer studies are coming which are refuting the claim that there is increased incidence of the bladder cancers. And these are, but still clinicians are reluctant to use these drugs, and now there are other drugs in the markets which have much better beneficial effects which are now being prescribed. So we have glucosidase inhibitors. Sorry, this is a little dark in color. So we have acarbose and meglitolol. What they do is they prevent the breakdown of sucrose and complex carbohydrates and thus decreases the postprandial glucose rise. It is effect limited to luminal side of the intestines and limited systemic absorption. So it doesn't cause systemic absorption. It remains within the gut, and that's why it's eliminated in feces. Reduces the postprandial glucose. Average reduction of the HbA1c is 0.3 to 1%. The main side effect of alpha glucosidase is it causes a lot of flatulence and a lot of uh, abdominal pain and gaseous distension, because it is preventing the breakdown of the sucrose and the complex carbohydrates, which are then broken down by the bacteria down in the large gut. Insulin, very important drug. The last drug which is usually patients think that when insulin is given, it's end of the life, it's end of the diabetes. There is nothing else could be done for the diabetes. But insulin is one of the best drugs which a patient can have, because it is the physiological thing which will be given. This is the thing which body is secreting, and this is the thing which has reduced, is not there in the body anymore in diabetic patients. So insulin is the magic drug for these patients. It is the life drug for these patients actually. So insulin has anabolic effect of glucose uptake, glycogen synthesis, lipogenesis, protein synthesis, and triglyceride uptake. Anticatabolic is inhibit gluconeogenesis, glycogenolysis, lipolysis, proteolysis, and inhibit fatty acid oxidation. The insulin commonly available is the U10, U20, and U100. We have the U100, the one while having 100 units of insulin in it. So there is pork. Source is either pork or human insulin. This is no more in use because it used to produce antibodies. Now this is the recombinant DNA technology, and human insulin is the one which is being prescribed. The pork one is no more, or beef pork is no more in practice. Onset and duration of effect, change in the properties of insulin preparation. So if insulin molecule is changed a little bit, alters the onset and duration of action. So we have Lispro, which is a monomeric, very rapidly absorbed. Aspart, which is mono and dimeric, is also absorbed rapidly. So these are short-acting ones, short-acting ones. Regular is absorbed rapidly, but it is absorbed slower than the Lispro and Aspart. So this, when you prescribe to the patient, you tell them take them with the first bite of the food, and this is when you prescribe them, you tell them to take them at least 15 minutes before taking food. These are called short-acting insulin, and these are basically used for the pharyngeal glucose, or for the rise of the glucose with the food intake they are used. Then there is long-acting insulin, Lentus or Lent insulin. It's a precipitate of insulin with zinc and insoluble crystals of insulin zinc. It is slowly released in the body. NPH, which has regular insulin along with protamine zinc insulin, so it is also released slowly in the body. And then we have glargine. It is a modified structure of insulin having microcrystals, and it is released very slowly in the circulation. This cannot be mixed with other insulins. So these are the insulins which are used as basal insulins. So these are given once or twice a day, and they maintain a level, a basal level of insulin throughout the day in the body. So what is the side effects? This can cause hypoglycemia. That is the main side effect. So patient has to be aware about hypoglycemic symptoms, the palpitations, the sweating, the restlessness, and the feeling of taking food. And whenever they have hypoglycemia, they have to be given 10 to 15 gram of glucose. This glucose should be given, the patient is advised to take juices, or he can take a glass of water with 2 to 3 spoons of sugar in it, or a glucose, or we have 15% or 25% glucose ampules available. You can, that is also given. And if patient is lost to conscious, then you give IV dextrose to this patient, or 1 gram glucagon IM if IV access is not available. So if you cannot give IV dextrose, then glucagon can also be given to them for hypoglycemia. So patients at the site of this injections, they can have skin rash, and it is usually more. So treatment is to give them more purified insulin preparation. Lipodystrophies, increase in fat mass, can occur at injection sites, so you have to advise them to rotate the sites of injection. So there are several drugs which can interfere with the glucose tolerance. Diazoxide, thiazide diuretics, which are commonly given to patients of heart failure. Corticosteroids with autoimmune disorders and several other disorders. You give corticosteroids that can cause increased levels of glucose, can cause hyperglycemia. Oral contraceptives, streptazocine, phenytoin, they all can cause the levels of the glucose to go up, and monitoring of blood glucose is required in these patients. So how will you give the insulin? You can give insulin with syringes or needles. There can be pen-sized injectors, and now the insulin pumps, newer therapy. The goal in type 1 diabetics is to balance the calorie intake with the glucose lowering process, insulin and exercise, and allowing the patient to live as normal as possible. So you have to maintain the diet with the insulin and exercise. They have to be managed in a way that patient lives a normal life. This is what I was talking about, the perennial. So what happens, there is a surge of insulin the whole day. There's one basal level of insulin which is not shown. You can consider a line going through and through over here. So an insulin basal level is there, which is there throughout the day. And when a patient takes food, then there is surge of insulin. So when you have taken a breakfast, and the glucose level, as the glucose level rises, the insulin level rises. Then again, as at lunch, you can see there's a, when you take the food, there is increase in the glucose level, and there is increase in the insulin level. And then supper or at dinner time, again the same thing happens. So this is how normally insulin is produced in the body, and this is what we try to mimic in type 1 diabetics or in type 2 diabetics when we put them on insulin therapy. So the short acting insulin, when you give short acting insulin, you give it here when the patient is taking the food. So that short acting will cover the breakfast, and then another dose of short acting will cover the lunch, and the third dose will cover the supper. And the basal, the long acting NPH or the glargine or lentils which you give will cover the basal levels of the insulin. The line is not apparent here, इसी वजह से नज़र नहीं आ रही है इस ग्राफ की लाइन, इसमें प्रोजेक्ट नहीं हो रही, but you can think that there is this basal insulin, it stays like that throughout the day. So for that insulin, to maintain that level of insulin, you give the long acting insulin to the patient. So the insulin regime has to mimic the physiological secretion of insulin with availability of the self-monitoring or continuous glucose monitoring and HbA1c test. The adequacy of the insulin regime can be assessed. More intense regime require more intense monitoring. So the more intense the therapy is, more the insulin injections you're giving to the patient, more you will have to do the blood testing of these patients. So there are several examples how you can give. You can give a morning dose before breakfast, give a regular and NPH or Lentus, and then you give an evening dose with regular or NPH. Requires strict adherence of the timing of the meal. So you fix the time of the meal. 8 a.m. in the morning, 8 a.m. in the evening, they have to take their meal and their injections. So you can give them twice a day, or you can these, and then there can be several modifications in this therapy as well. So at the night, what you can do is that you can also give at the meal time, you give the regular, and then going to the bed, when patient is going to bed, then you give NPH. You don't give it along with regular with the at the time when he's taking the meal. You do it when he goes to the bed. Or you can give 3 injections of regular or rapid acting insulin before each meal, and long acting insulin at bedtime, 4 injections. This is the best regime to follow. The choice of the regime will depend on the patient. So how much it depends on the patient, his health, his daily activities, his ability to take insulin to work. So it all depends on that. His ability to inject himself insulin. It all depends on that. So how much insulin you need to give? A good starting dose is 0.6 units per kg per day. Total dose should be divided 50% for basal insulin and 50% for prandial insulin. And then this 50% prandial insulin is divided into equal 3 doses. So for example, you have a 50 kg man, so you give a total dose. The total dose will be 0.6, the standard dose units, into the weight of the patient. This will give you 30 units per day. So 50%, like 15 units, should be basal, can be administered 1 or 2 doses. So when you give 1 dose, you give full dose together, or you can divide this 15 into half and give the 2 doses. And you have prandial, 15 units for prandial or for the meals, and you divide it into 3 equal doses. So that means 5 units for the pre-breakfast. Sorry, this one is wrong, it's equal doses. So 5 units for pre-breakfast, 5 units for pre-lunch, and 5 units for pre-supper. This is wrong, this is old regime, so you do not follow the 25%. It's 15-15, it has to be equivalent. It will be equivalent. So 5 units in the pre-breakfast, 5 unit pre-lunch, and 5 unit pre-supper. So how for type monitoring type 1 patient requires, so 0.5 to 1 unit per kg per day is the most type 1 unit. So most type 1 patients will require this much insulin. So you calculated it by 0.6, so you might need to bring it down to 0.5 unit per kg per day. So the range is between 0.5 to 1, and it is modified depending on the symptoms of the patient, the monitoring, the blood glucose monitoring the patient is doing, and the HbA1c of the patient. So according to that, you can decrease the dose or increase the dose of the prandial or of the or the long acting. Insulin pump therapy. This involves continuous subcutaneous administration of the short acting insulin using a pump. So a small pump is attached to the body, and that pump keeps on giving the insulin. It can be programmed to deliver basal insulin and spikes of insulin at the time. So it can be programmed. You can give, it will give a continuous short acting insulin as continuous, and at the time of the meals the patient can adjust the dose, give input to the pump that he's going to take that much carbohydrate or food, and then the pump will give the spike of the insulin. This requires intense self monitoring, blood glucose monitoring, and this is the best time when you can do continuous glucose monitoring. So most of the insulin pumps are now being connected to the continuous glucose monitors. Requires highly motivated patients, because failure to deliver insulin will lead to serious consequences like diabetic ketoacidosis. So this is 2 ways. You take a sample and you see, you check the glucose and then ingest the dose, or you can use the insulin pump. This is the insulin pump which is attached to the body. Then it has this transducer, and then this is the sensor which is attached to the body and senses the glucose levels. So the this this is a smart thing. Insulin pump is very smart. It will see if the sugar levels are falling, it will beep and it will stop automatically, or it will beep and advise the patient to stop the insulin. And if the sugar levels are high, it can be programmed to increase the dose of the insulin if the sugar rises. So whenever the sugar will rise, it will sense it and increase the dose of the insulin. So doses instruction are entered into the pump's small computer, and the appropriate amount